Welcome to our video on hepatitis B, parvovirus, and HIV in pregnancy. Let's get started. Here's our overview slide. Let's begin by discussing hepatitis B. During pregnancy, there is a 90% risk of neonatal hepatitis B transmission without prophylaxis. However, the risk goes down to less than 2% with prophylaxis. Risk factors for fetal hepatitis B virus transmission are high maternal viral load and a positive hepatitis B E antigen, which both indicate active maternal HBV replication. HBV is most commonly transmitted transvaginally. However, transplacental transmission is also possible. Prevention occurs by administering the HBV vaccine and hepatitis B immune globulin to the newborn. The HBV vaccine is a type of active immunization, and the hepatitis B immune globulin is a type of passive immunization. All right, let's try a quick question. A newborn girl is evaluated by a pediatrician. She was born 2 hours ago to a G1P1 mother at 37 weeks of gestation via vaginal delivery. The pregnancy and delivery were uncomplicated. The mother has a past medical history of chronic hepatitis B. The vital signs and the physical exam of the neonate are unremarkable. What is the best next step in the management of this newborn? All right, this neonate was born to the mother with chronic hepatitis B. Newborns of mothers with chronic hepatitis B receive the hepatitis B vaccine just like all other newborns, regardless of the maternal HBV status. Additionally, they should receive hepatitis B immune globulin to reduce the risk of perinatal HBV transmission. So the answer to the question is the HBV vaccine and hepatitis B immune globulin. Next, let's talk about parvovirus infection. Parvovirus B19 infects red blood cells and endothelial cells. In the mother, it can cause pure red blood cell aplasia due to red blood cell destruction in the maternal bone marrow. It can also cause rheumatoid arthritis-like arthropathy in the mother. On the other hand, transplacental parvovirus B19 infection of the fetus causes hydrops fetalis, which is a generalized fetal swelling due to severe anemia. Here we can see an image showing hydrops fetalis. Notice how swollen this newborn is. Okay, let's finish up by discussing neonatal HIV infection. HIV can be acquired via a transplacental or a transvaginal route by the fetus. The risk factors for HIV acquisition are high maternal viral load and breastfeeding by the infected mother. The maternal viral load indicates the degree of HIV replication in the mother. The higher the load, the more active maternal infection is, and therefore the higher the chance of fetal HIV transmission. HIV is present in breast milk, and this is how breastfeeding by the infected mother can transmit the infection to the neonate. Signs and symptoms of congenital HIV include chronic diarrhea, failure to thrive, generalized lymphadenopathy, and pneumocystis infection. The diagnosis of neonatal HIV can be done with a viral load measurement in the neonate. HIV antibody measurement in the neonatal blood immediately after birth is unreliable because of the transplacental transfer of maternal IgG. However, if HIV antibody persists in the infant blood after 18 months of age, it means that the infant is truly infected with HIV. Treatment is with antiretroviral therapy started as soon as possible. If the maternal viral load was less than 1,000 copies per milliliter at birth, then the infant should get only zidovudine. If, on the other hand, the maternal viral load is greater than 1,000 copies per milliliter at birth, then the infant should get a multi-drug antiretroviral therapy. All right, let's wrap up with the final question. A 3-year-old boy is born at 38 weeks of gestation to a G3P2 mother via vaginal delivery. APGAR scores were 8 and 9 at 1 and 5 minutes, respectively. The pregnancy and delivery were uncomplicated. The mother has a past medical history of HIV infection, treated with antiretroviral therapy, and her intrapartum HIV viral load was 200. Neonatal vital signs include a temperature of 36 degrees Celsius, a blood pressure of 60 over 40 millimeters of mercury, a heart rate of 150 beats per minute, and a respiratory rate of 52 breaths per minute. The physical exam is unremarkable. Which of the following is the best initial step in the management of this patient? A. Measure HIV viral load. B. Measure anti-HIV IgG antibody. C. Start antiretroviral therapy. Or D. Isolate the patient from the mother. This patient is born to a mother with an HIV infection. The maternal intrapartum HIV viral load was less than 1,000 copies, which explains why she delivered the boy via vaginal delivery. Even in a case where the maternal intrapartum HIV viral load is low, there is still a chance of perinatal HIV transmission. So we need to check the neonatal HIV status. HIV infection in the newborn is checked with a neonatal HIV viral load measurement. Therefore, the correct answer is option A. measure HIV viral load. This is the slide from our lecture reminding us of the diagnostic modalities and the treatment for neonatal HIV. And as we can see, it's diagnosed with a viral load. Now let's discuss why the other options are incorrect. Option B is incorrect because this baby boy will likely have a positive anti-HIV IgG antibody from transplacental antibody transfer. However, the presence of the antibody at birth does not necessarily mean that the neonate is also infected. It's only the persistence of anti-HIV antibody beyond 18 months of age that confirms HIV infection in infants. Option C is incorrect because we first need to diagnose the newborn with HIV before we start antiretroviral therapy. Option D is also incorrect because there is no need to physically isolate the patient from the mother. HIV is not transmitted via aerosolized droplets or respiratory droplets, although it can be transmitted via breastfeeding. So D is incorrect. And again, the correct answer is A, measure HIV viral load. And that concludes this section.